And that might be just one of these superpowers or just one of these hidden secrets that referral and university teaching hospitals.
Hi, I'm Hubert.
This is Gerardo.
And you are listening to the VetBob Clinical Podcast. Hello, VetVolters. This is another episode from our clinical series of podcasts. We did a whole series with specialist veterinary radiologist Dr. Steve Joslyn on tips for interpreting abdominal x-rays. This came from my own realization that I was relying almost entirely on ultrasound to help me diagnose abdominal issues, and totally neglecting radiology, which is actually a pretty crucial part of your workup if you are doing it well. What I didn't expect though was Steve's masterful introduction on how to make sure that you get images that you can effectively interpret. Basically, the secrets that specialist radiologists know that help them be so bloody good at what they do, but that we can all apply in our own practices. So, here you go. Enjoy. This episode is supported by our friends at Heska Australia, who are rolling out a very exciting new digital radiology product that could make your radiology a much smoother and effective process. A little bit more about that later.
So Heska's concept is we're providing you the whole package. You don't have to piecemeal these things together.
Steve, welcome to the show, mate.
Hey, thanks, man.
So when we talk about emergency imaging, one of the biggest challenges we have in an emergency clinic is that acute abdomen, painful abdomen, often really vomiting. I'm going to say dog, mostly dog, but obviously cats as well. And having to make that decision, is this a surgical emergency or is it a medical emergency, or if not surgery, some sort of major intervention? What immediately springs to mind is foreign bodies, but obviously other stuff as well, septic abdomens, all those sort of things. Now, the trend I see, and certainly I'm, let's call it guilty of that, is we started with the radiology, with x-rays, when I was a recent grad and a new grad, and then ultrasound became more and more commonplace. And I personally spent quite a bit of time learning about ultrasound and got more and more confident and comfortable using it, to the point where now if I have an acute abdomen, I'll generally reach for ultrasound first. I feel like I get more information from it. If I'm going to do x-rays, it'll basically be to see, have you swallowed a stone or a coin or a bone? Are you really constipated? And have you broken a bone somewhere? And that's about how I use it. But I know that we've had a disagreement about this, and you feel very strongly that radiology still has a very good role to play in emergency abdomens.
Yeah, sure. So, I mean, in the last sort of 10, 15 years, there's been a solid amount of papers that have just looked at comparing the sort of utility or the accuracy of ultrasound and X-ray, and then also CT. Like CT is an interesting one that we can talk about soon as well. But I think the take-home message, and maybe we should leave the take-home message to the end, but the take-home message really is that our tendency, especially maybe in those super stressful scenarios where the emphasis is on finding the answer, our tendency is to go, what is the one diagnostic test that's going to give me the answer? And we look at, oh, that's either ultrasound, or it's this, or it's that, or it's hematology, or whatever. And I think the better approach, or I guess the better way of thinking about it, is really, what diagnostic test do I have that's really going to hone this down? And because ultrasound has its limitations in either the user's ability or the conditions that ultrasound is not good at detecting, or the states of, free peritoneal gas, those sort of limitations mean that X-ray radiology will come out on top for certain conditions. And so then saying, hey, we have acute abdomen, what if we did them both? Or what if we did a few different things here? Would we have a lot more confidence on that is the cause of this acute abdominal presentation?
I hear what you're saying. I totally hear what you're saying. And I think for most vets still, the reason we want to choose one over the other is exactly what you said. You want to choose one that's most likely going to give you the answer. And it's because we don't want to waste people's money. But that's probably a whole conversation about trying to save their own money, whereas actually you should be focusing on getting to the best answer.
Yeah.
So it's
right.
like the Targos debate. It's the soft versus hard. Well, why not have both? You should do both. That's, I think, and we were taught that. I specifically remember in imaging we were taught, don't pick one, do both. Otherwise, you're going to miss stuff.
Yeah. So I guess if I look back, and there's a few universities I was involved with where part of the price of a ultrasound included abdominal survey radiographs as well.
Yeah.
And with that, obviously some of them were just strapped for time, and so they just quickly rush in and out of ultrasound.
Mm-hmm.
But for the most part, we got all of them through abdominal radiography as well. And the good thing about that is that you have somebody separate looking at the x-rays that's doing the ultrasound, completely blinded. And although we didn't write any of those papers, there's been a few, and they just show that both of them, when performed by, of course, the specialist trained radiologist or the resident in training, really good diagnostic accuracy or sensitivities and specificities for some of these conditions, acute sort of mechanical obstruction and that. But having a little bit of information, like for example, if you're looking at an intestinal obstruction, there are some key imaging findings that would drastically affect the prognosis, and that would be free gas. I mean, indicating that it's perforated. And ultrasound is terrible at finding very small amounts of free gas. And so on an x-ray, if you have a gas cap sitting up near the diaphragm with your intestinal obstruction, or just porous rows of detail because it's an angry abdomen, and then you go to ultrasound and say, wow, there's a massive intestinal obstruction here. Just doing ultrasound alone might mean that you're going into something that's already necrotic and septic, septicemic in that. And so that's the best case scenario. Ideal is you have both of them together and you have the time to look at them. And I think that's just obviously, as well as that's not a reality for everyone.
So you mentioned free gas. Is there anything else that jumps out at you that you think, no, this is where X-ray is going to be superior in picking stuff up? Are there any conditions that spring to mind for you?
I guess the first thing that springs to mind is really that global assessment of the abdomen. And I don't want to guess the way you're doing an ultrasound in that sort of stressful period of an acute abdomen, but when we're going through an ultrasound to look for a problem, we think it's going to be mechanical obstruction. You're probably not interested in that piece of liver that's floating by, or the spleen, or all of these, even adrenals, right? You're probably honing in on the digestive tract and maybe the pancreas as well.
Yeah.
And with that, there might also be some other clinically significant or totally unrelated and prognostically significant lesions. Like maybe there's a massive adrenal mass or a functional small adrenal mass, and it's just a little bit asymmetric, or a nodule, a mineralized nodule that's just off in the corner. And so if you're going to do the full abdominal ultrasound and really cover all of those, then that's fine. But I think in the emergency setting, maybe the tendency would be is that you find that duodenal obstruction, you're probably, you're out. So, so if that's the case, then the abdominal x-ray is going to give you just a little bit of an overview of everything, and just look for any of those extra comorbidities or concurrent diseases, or maybe that that incidental but significant spinal tumor that is just on the edge of the film. And so that's it. And I guess the other question goes too is like, if there is a complicated case in the emergency setting at these emergency centers around Australia, and I should even say around the world, what are the chances of that being referred to another tiered emergency center? And I feel like it's probably minimal, right? I think that patient is there, or it's nowhere. That's where it stays. And so I guess with that as well, and finances all considered, doing everything to make sure, like if this is an elderly patient, maybe that's a time to say, hey, listen, it looks like he's eaten something and it's obstructed, but he's suffering from all these other conditions too. And it would be really unfortunate, the fact that we're looking here, to not look, just in this entire region here, just to make sure there's nothing else going on as well. Because, a 16-year-old dog, there's probably going to be some other things going on too. And we see that a lot too. So acute abdomen, large splenic mass on the tip. It's totally incidental. It's not clinically significant yet until it does rupture. But that's the sort of thing that happens. And I think by bringing in abdominal x-rays and ultrasound together, it's a little bit of time, but I
Yeah.
think the amount of information and then confidence and those cases where you start to pick up something extra or just a little bit more information for, the surgery group that before they go in, I think that's probably, as best practice as you can. And if there's
Okay.
an opportunity to do that in these emergency centers, I think that's probably reasonable.
Okay. I'm sold.
And I mean, there's another limitation as well. So this is all before we get into the interpretation. One of, I guess this is a story that I think is quite common with most veterinary centers, at least all the ones I've seen. And I've traveled a lot through visiting lots of referral centers, GP practices lately as well, and then university hospitals. But in the university hospital, or usually when there's no radiologist in the building, the clinics that I went to visit, and pretty much all of them now, the way that they view their radiographs are on the same screens that they're doing, quality assessment and the radiography screens, right? So those are like touch screens. There's finger smears all over them. They're probably some of the cheapest monitors that you'll ever find because most of the price went into the actual X-ray machine. And I think that contributes to some people's lack of confidence because I can't see anything. There's no doubt that nobody can see anything on that screen. So I visited one big hospital. They asked me to have a look at their X-ray suite outside of surgery. They hated it so much for post-op radiographs that they would cart the patients in through the elevator, down through reception under GA to go into the other radiography suite because they preferred those X-rays better. And so I said, hey, sorry, let's just walk through this. When's your next surgery? Let's take X-rays upstairs, exactly the same settings, positioning, exposure settings, everything. And we'll do them downstairs as well. And so we did that. And then I loaded them, both sets of DICOM studies side by side, up on my nice MacBook Pro with a Retina display and DICOM viewing software, and they were identical. And they realized that they've been trying to interpret post-op X-rays, orthopedic X-rays, or anything off of a touch screen. And it was a very quick fix. All they had to do is just say, hey, diagnostic interpretation and viewing shouldn't be done on these screens. And we're always promised that those screens are good enough by other people selling us a system, but really a iMac or a nice Dell or LG monitor running some open source DICOM viewing software in a slightly darker area or just around the corner is perfect.
I really like that. I've never thought of that. We just look at the pictures where we take them, almost.
Yeah. And that's the tendency as well, though. You're going to be there right as an image pops up, and you're going to be like the first to spot the foreign body and that sort of stuff. So that's called the 5-second diagnostics, and that's got a bunch of inherent flaws in it. So try not to do that. So before we get into the interpretation, that's another thing. And then also, I guess everybody my age and likely your age as well, we learned off of film screen exposure settings and finding perfect exposure that balance the contrast across the film for the body part that you're looking at. And it's all changed with digital radiography and computed radiography. The old rules that we have with increase in KV affecting the contrast and MAS and that's all kind of gone out the window. And I haven't really seen that refresher course or that refresher piece of publication saying, hey, forget everything you guys used to know about KV and MAS. This is all you need to know. And that's, I think, missing. So what I find now is that still when people send me radiographs, the amount of overexposure and underexposure that happens is still as common as it was when we had film screen. And yet we were always promised that it was going to be way better. These images were going to be amazing. But because we don't know film processing like we used to, we tend to go and panic and go, oh, just up this or take that away or window that and that'll look better. And we kind of lost that control over the X-rays. And so with DR and CR, a lot of that work is done for you, provided you give just the bare minimum of exposure details. And so with that, as long as there's enough MAS, if there's enough photons hitting the plate and passing through the patient, most of the lookup tables and the post-processing will give you a adequate image. And so, to the point now where KVP is not adjustable as it used to be. And a lot of the exposure settings are the same for regardless if you're doing abdomen, thorax.
Yeah, I've noticed that.
Yeah, and what's changing is the pre-processing and the post-processing that basically fit that body part to match its lookup table. And what the lookup table just says, like, hey, if I'm told to look for a femur, I'm going to make that femur look beautiful.
Yeah.
And if I'm told to look for an abdomen and you give me a femur, I'm going to make that femur look like an abdomen.
Yeah, okay.
So that's why it's really important to be super strict that if you're taking a right lateral radiograph, make sure the digital system knows it's taking a right lateral.
Okay, so it's not just for identification, it actually helps the software make the settings look the best.
It's the superpower behind digital systems, and I think it's probably underappreciated by most.
100%, because I see it all the time, man. People just go, yeah, click, because you have to decide beforehand which images you're going to take, and they just go abdomen, and they do the whole dog on that same setting.
Yeah. And so the other thing too is that I see, and again, I just mentioned the orthopedic studies. Sometimes I'll get given an orthopedic study, and the stifle looks great, but it's also including the hips, the pelvis, and the caudal abdomen, and a bit of the spine, and maybe the hock. It's just a big image. And you know how digital imaging, like, it's made the whole thing look great, but the lookup table has applied that orthopedic setting over the entire caudal abdomen, hips, and hock. And because it's had to concentrate that processing power on everything, it's kind of minimized its effect on what you're actually interested in. So by collimating to the region of interest as strictly as you can, gives all of that processing power and lookup table sort of pre and post processing the maximum ability to make that look beautiful. And that's why collimation is still super important. So one of the quick ways that you can compare this is just to do a stifle study, but include lots of pelvis and lots of hock and lots of table, and set it up on that setting, and then do an identical one with collimation right down to the stifle, same exposure settings, make sure there's enough MAS, so enough photons hitting the plate, and compare the two zoomed in images. And you'll notice a massive amount of orthopedic bone detail that you wouldn't have seen previously. But that same line of thinking works for the abdomen too. It's like if you collimate, just include the abdomen and not the thorax, it's not going to try to make pulmonary vasculature look great and the heart look great and ribs and all that. It's going to say, you know what, I'm just going to concentrate on the abdomen. So that's, again, another thing before we even start interpreting, just another skill set or another emphasis that you can do to make what you're looking at look the best that it can be.
Fantastic. Hey everyone, we're going to interrupt Steve for a minute to hear from the team at Heska Australia about how your radiology setup can be better.
It's a concept that we're selling, which is we provide you with diagnostic images and leave the rest to us.
We have David Miskimen with us from Heska Australia. I know, David, we talked about titles before. You said you don't like titles, so should we just say David is the heart of Heska Australia? Does that sound good?
You might even be worse with that, but yes, let's take it. So I look after Heska Australia, along with a pretty well-equipped team.
So David, our listeners will know about Heska from some of our previous episodes, and they'll know that you guys are providers of in-house lab equipment. But now you have a new thing. You are bringing big changes to veterinary radiology as well. So with your lab stuff, you saw some shortcomings in the in-house laboratory space that you addressed really elegantly. What's the problem with radiology and veterinary science? I think we get so bogged down as vets in working with it, and you work with it and you get so used to it that you don't always see that there could be a better way. What do you guys see as the problem that needs to be solved?
So it'll be common knowledge that for any who have adopted digital radiography or direct digital have experienced issues around software updates, the product not working, the left hand not talking to the right, so to speak.
Yes.
Where This is ultimately the problem that we first set out to solve, providing a end-to-end solution that Heska has developed, built under the Quattro brand from the ground up, specifically for veterinary application. And that includes the acquisition software, integrating with the plate, the data storage, the image review, measurement and retrieval using a CloudPax solution.
Okay.
And beyond that is the service and support that comes in behind it. And what Heska aim to do is offer a product in which you don't have to consider any additional or ongoing costs. And this really should see us differentiate ourselves from the status quo.
Yeah, absolutely. So what you said there is totally true. I've worked in only 2 clinics in the last 10 years, and in both of the clinics, it's such a common thing. X-ray's not working. When it works, it's so simple because you hit a button, pop, pop, and it's there. But the biggest issue is plate's not talking to the computer, or computer's not loading it, or I can't find the images when I want to review them later. So are you guys fixing that? Because that would be awesome if you can fix that for us.
Absolutely. Problem solved. What we offer is a product that is the end-to-end solution. We're not acquiring a plate from vendor A, a software from vendor B, and a computer from vendor C, and piecemealing them together.
Yep.
Our product is Heska, and with that we control the updates, be it by Windows or anything else. And this is where the problem really lies for anything up until this point, that component was out of the supplier's control. We manage and mitigate any issues around that by having an embedded software that when you set up a Heska unit, it is Heska.
Yeah, so we had this in our clinic recently where there was a licensing issue. It wouldn't work. The two wouldn't talk to each other. Plate wouldn't talk to the software. And you'd contact the company and they say, not our problem, that's a software issue. And then you talk to the software guys and they'd say, not our problem, it's the other guys. And it's exactly that. It's sort of Frankensteining a finished product together from different companies. Whereas I love the sound of having just one thing. So just to be clear, let's say I don't have DR, we're using CR, or I don't know, I'm setting up a new clinic and I don't have any X-ray stuff. Do you guys sell the plate as well? That friggin' expensive thing that you have to treat like a little baby? Because do you guys sell? Can we get that from Heska as well?
Absolutely. So the first thing to think about is, I guess, divorcing the two X-ray generation and digital radiography. They're two separate components that work together to give you digital images. Mm-hmm. What we're looking at here is the image acquisition and the digital radiography side, mm-hmm. where X-ray generator, you may have an existing setup in your clinic and we can retrofit to that and convert your existing site upgraded to digital. Mm-hmm. But if you need a generator or if it's a new fit out, we can provide that also.
Okay, brilliant. And then how does it talk to your practice management system? Can you store stuff on your patient files or access it easily to email to referral centers or clients, or how do you access the images off the acquisition computer?
Absolutely. The PACS server will interact with any DICOM compliant practice management software.
Okay. So you can set it up to that I can access it from my PIMS.
Yeah. This is a broad question as well, because not many people would do it to the level that it can. So can you interact with practice management softwares? Absolutely.
Yeah.
To what level? The world's your oyster. You can have it doing everything or as much or as little as possible. It could be on a tablet, it could be on a PC, it could be on anything, and you can review it that way.
Gotcha. Okay.
Yeah.
It sounds complicated to set up. Is that part of the support thing? Would you set stuff like that up? Is it part of the service, or is it something that? Yeah, it is.
Absolutely, we set it up. So what we want to do is go in and install the equipment, set it up within your clinic to the level that you require, and walk away happy that you're acquiring perfect images. If anything happens down the track, give us a call. We sort it out 24/7, 365 days.
That sounds really, really good.
Yeah.
I'm going to talk to the boss. It sounds like there's a hell of a lot of improvement that most practices could make with their image acquisition and how we manage our images. Things could be better. You just don't understand how much better. And
you don't know yet.
And basically call David at Heska and say, how can it be better? Here's what we've got. How can I make it better? Yeah.
And this is what we want to do, is make it a simplified solution, as complicated as it may sound, by bundling the point of image acquisition right through into storage, review, retrieval, archiving files, the whole works. We want to provide digital radiology as an end-to-end solution. If you ever interact with it, we have it covered.
I like that. People talk to your bosses, get them to call Dave. Things can be better.
So then, and I don't know if I'm going to be popular with your listeners or unpopular, depends on who's listening, but I think in a busy radiography department, and you get to a certain level, you probably want to have a veterinary nurse take ownership of radiography. And that's either somebody that rotates through or somebody that's kind of always kind of responsible in owning the quality and the caseload and the scheduling and all that sort of stuff through radiography. And the reason why I say that is vets, the attention span for vets is to find the problem and to move on. And vets also don't get distracted. Whereas if you see a veterinary nurse that's doing radiography, especially in some of these referral centers or busy GP centers, they don't care what the vet thinks about what's going on with the animal. They are trying to get the best views that they can. And they quickly go, hey, have I got all the studies that you need? And are they appropriately, rotated and aligned? And if you say, it's a little bit rotated and it's like a degree off, then you get the scowl and look at so don't piss them off. But the thing is, when you get to that level, veterinary nurses follow radiographic protocol much more strictly than vets, and they're not distracted about what's going on. And their task is, I'm going to get these, make them perfect, and I'm going to get them collimated, and I'm going to send them. And the beautiful thing about that is that it actually frees up a vet from doing the radiography and tying them up for 10 minutes, 15 minutes, half an hour. Instead, they could be into the next consult or, tend to that case. And then when it's ready, boom, they have all the images they need on a nice screen, and then they can obviously go on from there. I used to work at the University of Illinois, and we had 7 veterinary nurses or vet technicians. And if I ever walked into X-ray, they'd usually go, can I help you? Why are you here? So then get out of here. and that's kind of the way it should be. That's their domain. That's and our domain is in front of the interpretation screen. And if you can trust somebody to take control of imaging, then they're going to get 3 views out of them every time, and they're not going to get stopped halfway through because you found a foreign body. And I think there's a lot of value in that.
I can see that. I like that. That's really good advice.
I have a lot of other suggestions, and I guess one of them is the database of normals and abnormals. I mean, how many clinics that you worked at where you have a database of normals to reference or abnormals to reference?
So like a file on the computer that says, here's 10 cases of let's say a foreign body, or is that what you mean by database?
Yeah, 10 cases of a small intestinal foreign body in a middle-aged Labrador.
No, I've never seen that.
Yeah, and so that might be just one of these super powers, or just one of these hidden secrets that referral and university teaching hospitals have, is we have these databases to compare. So having normal to compare is super important, and also having other abnormals to compare as well. And things become far more obvious when you do so. So subtle areas of focal loss of cerebral detail, when you see it compared to a normal, it's so much more obvious. Whereas if you see it by itself, it's equivocal. And having that readily available is also useful. And that just means that a database system that you can quickly search for Labrador abdominal obstruction, intestinal obstruction, and it will pop up. And so going back to the dedicated viewer that some of these emergency centers should get, is that if you had something like the free DICOM viewers, where there's Horos and there's Clear Canvas and there's a few others, they allow you to tag studies after the fact.
Okay.
And then you can search that. But also, Osiris is a paid version on Mac, and obviously all the imaging software that you have when you buy your X-ray system should have an ability to tag that. And it takes a while to build up over time, but that's what we do in referral hospitals. I guess we'll quickly talk about the views. So we were originally taught 3 views for an abdominal series is what you need. And Now they're starting to push towards 4 views, so doing left and right lateral as well as VD and a DV. And do you remember yourself why we're doing at least left and right lateral comparison?
Is it gas? Is it because of shifting gas patterns?
Yeah, that's exactly right. So just that valuable information. And if I look back at some GP radiographs that they send me, they might only include the right lateral abdominal review and VD or DV, hopefully VD rather than the DV initially. But the right lateral view is not that good for detecting duodenal foreign bodies because you want the gas to go up to that right side, down into that duodenal loop, right? And so if by doing a left lateral, that gas is going to now fill the pylorus and then the duodenum as well, and really highlight if there is an obstruction there. So the gas differences really help and has this shift, but then also if there's free gas, the way it shifts amongst, through the liver lobe.
Okay, cool.
Through the viscera as well. Now, the other thing too is that we talk about inspiration and expiration a lot with thoracic imaging.
Yeah.
Inspiration and expiration, we want the exact opposite. So we really want full expiratory views on an abdominal, a standard survey abdominal series. And the reason being is that we want that tissue to be as thin as possible. And obviously thin as possible means that you're going to have less scatter produced. But the whole expiration, inspiration, it doesn't change abdominal contrast at all because the contrast is not provided by aerated lung. It's provided by fat and viscera and soft tissue and gas within the lumen. So it doesn't change anything there. So we just want it completely nice and still and thin as possible. And obviously the three views. They started suggesting the fourth view really to help with that gas as well, because in that VD position, all the fluid is collecting in the duodenum and the pylorus, whereas in the DV position, the gas is now rising up to the pylorus and up to the duodenum that kind of hugs the right kidney. So it's not a great view for seeing everything, but it does help with that little bit of gas information of how things are shifting. So I'd suggest, if possible, get the 4 views. In America, when we were there, they did everything under completely conscious and holding with appropriate sort of radiation protection gear. I think it's an interesting topic. It's like only when necessary. I think of the guidelines here in Australia. It's like when you have to hold, then you have to hold, but otherwise you should be doing everything with sedation or chemical restraint, physical restraint. And I don't want to say you should feel comfortable holding if you need to, because I do think the concern about radiation exposure is always valid. I think there's also the other side to that is if you're not getting that good quality abdominal radiographic study because of rotation, then it's not helpful anyways. And that extra bit of exposure that you got for that poor quality radiograph is actually just been wasted. So I think that you could justify, with a bit of sedation and potentially having to hold for these emergency situations. I think that's justifiable. If we talk about the levels of radiation exposure for people in our profession, and that includes nurses as well.
Yep.
If you are appropriately gowned, full suit, thyroid protector, and gloves, and no pieces of body in the primary beam. If you are gowned, then your risk is, what was the stat? We're not in any levels of radiation exposure of any concern. People in those emergency critical scenarios feel that they probably can't get a good quality x-ray because they can't do sedation or they can't do GA in that case, and therefore they're kind of stuck because they have to chemically restrain them with physical aids, and it's a crappy image. And so I think the justification is there is that if you do need to get good quality images, then that's the professional decision that we make, saying, no, we're going to have to get up and hold this, and knowing that our colleagues in America do this all the time and that they haven't demonstrated increased risk.
That's interesting. That's actually reassuring to hear, because I think you'll find in emergency there's a lot of holding, and it's a I think a lot of people feel a little bit guilty about it, like, fuck, I shouldn't really be doing it, but I'm in a hurry, I can't be bothered, I'm just gonna hold the bloody thing.
Yeah, thyroid protectors, bodysuit, not bodysuit, just chest protectors, and then also wearing your dosimeter on your person, so underneath your obviously your lead gown.
Yes.
So don't wear it on
Don't
the
go
outside
and
of the lead
zap
gown.
it.
Don't leave it on the dashboard of the car. It should literally just be on you when you're in the X-ray room. I just don't want to get in trouble by somebody listening to saying we shouldn't be encouraging that at all. But I just think otherwise you're getting a poor quality image and the whole thing was a waste, including the extra bit of radiation you got for that wasted image.
That makes me very happy. Thank you, Steve. If you like that and you want more practical clinical content with world-class specialists that you can consume on the go, then go to thevetvault.com and click on clinical content for a free 2-week trial so you can binge listen to as much radiology, emergency medicine, surgery, and small animal medicine as you want. All backed up by summarized show notes so you can refer back to it later. And if you need to update your radiology suite, go and check out Heska's all-in-one end-to-end product at heska.com.au.